Good evening, everybody. Today is the 8th episode of the ENDOVISION webinar. It's known as Mega ENDOVISION. Indeed, it has 3 sessions, and this series has been going on for last 8 months. Every second Wednesday of the month, we have this webinar. But this time, we are having it on Sunday, the 4th of August. And it is the brainchild of none other than our visionary and dynamic leader, Dr. Bhaskar Pal. So at the onset, before the academic session starts, I would request Dr. Bhaskar Pal, sir, to please give the welcome address. Admin, please share the CV.
Thank you. It's not required. Is it? Thank you. Thank you, everyone. Thank you, Poshali. Stop showing the scene. Good evening, everyone. I welcome you to the mega episode. We started off with a mega episode in January, which again, we did it on a holiday because it becomes very difficult to get 3 hours out on a weekday. And we welcome you again today. And I think endoscopy we run several series, including one on fetal medicine, one on infertility and reproductive endocrine, and one on routine obs and gynae. But endoscopy gets the highest attendance. The last episode last month got a live view of more than 1100. And this is not to count the post views which happen after the event. I'm grateful to Dr. Nutan Jain Madam for being here as a guest of honor and all the faculty for being here today. The whole idea of this episode has been mainly to have as much of video base as possible in the lectures so that people it is a good teaching tool. And in the form of the panel, a bit of discussions about what is safe and what isn't. I would take this opportunity to thank our sponsors, Alembic Pharmaceuticals, for supporting us, and also Conference International for being our publicity and platform partners. It is easy to dream of something, but it is impossible to execute it unless you have a good team. And I'm grateful to the co-conveners, Dr. Ashish Kale and Dr. Subhash Malia, and the 4 national coordinators, Dr. Amok Chimote, Dr. Aditi Tandon, Dr. Paushali Shanyal, and Dr. Pen. Last but not the least, the Foxy elections are going on. And as you know that I'm contesting for the post of Foxy president, so I have 2 requests for everyone. Number 1, please vote in large numbers. And number 2, if you think that I am deserving, please vote for me. With this, I will hand it back to Poshan.
Yes, sir.
Thank you so much, Bhaskar sir. We move on to our academic sessions. Before the session 1 starts, I would request our guest of honor, Dr. Nutan Jain Madam, to please say a few words. Madam is again very well known in the field of endoscopy, a very senior endoscopist, director of Vardhaman Infertility and Endoscopy Center at Muzaffarnagar, India. She conducts regular fellowships, live surgical events at her center, and she has been elected board member of International Society of Gynecological Endoscopy in 2006. She is the author of various textbooks of laparoscopic surgery, and we welcome you all, Madam, to give your welcome address.
Thank you, Poshali. Thank you, Dr. Bhaskar, for giving me this opportunity. And it's my pleasure to be here among the luminaries here, Dr. Bhaskar, Dr. Kalaskar, Dr. Rajesh Modi, and Dr. Bijoy Naik. And we are missing Dr. Rekha. Maybe she's joining in a while. So, this ENDOVISION matches up with my passion. My feeling is that each and every gynecologist should be having a laparoscope and hysteroscope in her armamentarium. In the present scenario, when the disease pattern and the disease quantum is rising so much, and all patients are demanding a laparoscopic or a minimally invasive surgery, then no gynecologist should be remaining without the access to laparoscope and hysteroscope. And I strongly feel that this series of ENDOVISION episodes starting from January, every Wednesday, Dr. Bhaskar himself said, last episode had 1100 audience. So this itself shows that there is a huge demand and a huge interest. And if we have Dr. Bhaskar at the helm of the affairs of Foxy, as the Foxy president-elect, this dream and my passion and so many endoscopists will be matched. So I request Dr. Bhaskar, all the voters who haven't voted so far to please vote. And if they consider Dr. Bhaskar as my choice, and if they also consider him eligible, to vote for him, and let us have a better future for endoscopy. Thank you so much, and thank you for the rest of the evening and academic session. Thank you.
Thank you. Thank you, Dr. Nutan.
Thank you so much, Nutan ma'am, for those inspiring words. We now move on to the first session, where we have two very eminent endoscopists of India, Dr. Pandit Palaskar and Dr. Rajesh Modi, sir, who will be speaking on retroperitoneal spaces and managing complications in laparoscopy. And to chair the session, we have two other very eminent chairpersons in the field of endoscopy. Our first chairperson this evening is Dr. Bijoy Nayak, sir. We welcome you, sir. Sir heads the department and he's the Senior Director, Minimal Access and Robotics in Max Super Speciality Hospitals, Delhi. Sir has areas of interest in gynecological surgery and hysteroscopy, laparoscopy, and robotics. Sir has been the ex-chairperson of the Endoscopy Committee of FOXI, an executive member of IAG Delhi, and Sir has been honored by Chief Minister Odisha for his contribution to minimal gynae access surgery. We welcome you, sir. Our next chairperson this evening is Dr. Rekha Kurian, Madam, another eminent endoscopist, director and consultant of Joseph Hospitals, Chennai, honorary consultant, Southern Railway Headquarters Hospital, Chennai. Ma'am has been the past president of OGSSI, vice president FOXI. In the past, she has been a member of the managing committee of IAG, and she has been the vice chairperson of the Tamil Nadu chapter of IAG. We welcome you, Madam. I would like to hand over the proceedings to the chairpersons for our next session. Thank you.
Good evening. It's our pleasure to be here. I think Dr. Bijay Patnaik and myself, we will be taking over on the session. And it's we have a great session ahead of us, which is going to be, the speakers are going to be Dr. Rajesh Modi, of course, well-known eminent endoscopist who gives a lot of training sessions, and as well as Pandit Palaskar, the past president of IAG, and again a very eminent and erudite endoscopist. So I think we will move on. Dr. Pandit, you want to say something? Dr. Bijay, you want to? Yeah, Bijay, do you want to say something before we start?
Yeah, yes, it's my pleasure, and I feel honored to speak in this forum, and the sitting elites of the endoscopic surgeons of India and Rajesh Palaskar. Both are known for their fabulous work in endoscopic surgery in India. They are equal to anybody in the world. What to say about India? Let us learn something from them and listen to them. Thank you. Thank you so much.
Yeah. So this, I think the first speaker is Dr. Pandit Palaskar.
Yes, ma'am. Yes, madam. Yes, madam.
Yeah, over to you, Pandit Palaskar. I don't think we have your CV is here. Of course, as I just said, he is invited as a very popular operating faculty in all conferences, and he has published a lot of papers, case reports. In fact, I was one of the first who invited him to an operating session in Chennai. So I feel very proud that I did give him an opportunity at that point. But he has now been the president and well recognized in his endoscopy teaching center, which he has. Over to you, Pandit Palaskar.
Thank you so much, madam.
Yeah. I think your slides.
Yeah, I'll share the screen. Thank you, respected chairperson, for the kind introduction, and thank you, Dr. Bhaskar Pal and the team for giving me this opportunity to talk a very interesting subject, that is the retroperitoneal anatomy. Can you see my screen?
Yeah, you'll have to make it enlarge the screen.
Enlarge, yes. Yes, that's fine. That's fine.
Yeah, pelvic anatomy through the laparoscope is a very important subject if you want to advance your surgical skill into the retroperitoneal, and when you are handling the complicated cases where the pelvic anatomy is totally distorted, frozen pelvis, and you have complicated patients. I think in those cases, the knowledge of the retroperitoneal anatomy is very important. The patients with distorted anatomy, patients with difficult cases, complications, in all these patients, the knowledge of retroperitoneal anatomy is very important. And when you have the knowledge of the retroperitoneal anatomy, I think you cross all these boundaries and manage these complicated patients. The retroperitoneum, it provides unlimited possibilities. It provides access to the retroperitoneal organs. It provides the access to the vessels. It provides access to the nerves, and any retroperitoneal pathology you can tackle when you have the knowledge of the retroperitoneal spaces. These are also called as the virtual spaces, because these are not the spaces that are already present. We have to create these spaces early in the surgery, and they provide very crucial role in the function of the urinary, reproductive, gastrointestinal systems, and the knowledge of these spaces allows the restoration of the altered pelvic anatomy in the complicated patients. Basically, these spaces, they are limited by at least two independent fascia, and they provide the anatomical landmarks in the retroperitoneal and pelvic surgery. And these spaces, they exist as the pelvic viscera, the Mullerian viscera, the other, these are derived from the different embryological structures. That's why they are limited by the different pelvic spaces. Basically, these spaces, they are avascular spaces, and they are named according to the location of these spaces to the nearest organs. Suppose the space lies nearby the bladder, it is called as paravesical space. If the space lies lateral to the rectum, it is called as pararectal space. Suppose it lies in between the bladder and the vagina, it is called as vesicovaginal space. So you don't have to remember the spaces, you have to remember where the space lies, and according to the location of the nearest organ, the spaces they are named. The roof of all spaces is formed by the peritoneal lining, and the floor of all the spaces, it is formed by the pelvic floor, that is the levator ani muscles. Basically, there are two types of spaces: median spaces, which lies in the midline of the pelvis, and the lateral spaces, which are the paired spaces, which lies lateral to the uterus and the bladder and the rectum. So median spaces, they are, if we start from anterior to the posterior direction, when the patient is in the standing position, it is the retropubic space, which is also called as the space of Regius. Then comes the vesico-vaginal and the vesico-cervical space, which lies between the bladder and the cervix and vagina. Then the recto-vaginal space, name itself suggests it lies between the rectum and the vagina. And the recto-rectal space, which lies behind the rectum, in between the rectum and the sacral promontory. So these are the four median spaces. Then comes the lateral spaces. These are the three paired spaces: paravesical, lateral to the urinary bladder; pararectal, lateral to the rectum; and yabuki space, which lies in between the ureter and the vesico-uterine ligament. So these are the lateral paired spaces. This is a diagrammatic representation of the spaces. We can see from anterior to posterior all the spaces, and the lateral spaces just we have described. This is another diagrammatic representation. Now you can see this video, which shows all spaces in the pelvis. So this is a lateral approach to retroperitoneal. It is also called as gateway to the pelvis, where we start by cutting the round ligament and enter to the retroperitoneum by the lateral approach. Once you open this peritoneum lateral to the IP ligament, the first structure we see is the vascular tree, that is the internal iliac tree, and the ureter. Ureter lies medial to the vascular tree, and the internal iliac is lateral to the ureter. You can see all the branches of the internal iliac artery and the posterior division. Here you can see all the branches of the internal
Video
eye
is not moving.
Video not moving.
Video is not moving actually.
But this video is not moving.
Pandit sir, you're muted.